My name is Dinesh Khanna. I'm a rheumatologist and take care of people with scleroderma at University of Michigan. These are my disclosures out here, and in any medical meeting we provide, and most of the work is trying to find new cure and the treatments for scleroderma. So these are points that I'm going to talk about here. I'm going to talk about the screening of pulmonary arterial hypertension. I'll talk about the difference between pulmonary arterial hypertension and pulmonary hypertension. There's a big difference between the two. Does anybody know that? Okay, I'm going to come and ask you that question. How to diagnose pulmonary arterial hypertension, how to treat it, and then the collaboration between a cardiologist, a pulmonologist, and a rheumatologist trying to manage this disease. So pulmonary arterial hypertension is seen in all the connective tissue diseases. If you have rheumatoid arthritis, if you have scleroderma, if you have lupus, PAH is seen in all of those diseases. And pulmonary hypertension is one of the leading causes of death in scleroderma. So if you have pulmonary arterial hypertension, if not treated appropriately, is the leading cause of death. And the medical treatment is similar for IPAH. It means idiopathic pulmonary arterial hypertension. People where we don't know what caused their pulmonary arterial hypertension, they don't have a connective tissue disease, but the benefits are somewhat less robust compared to IPAH. So when you look at this slide, this slide is from Dr. Steen and Dr. Metzger from University of Pittsburgh database. And what you're seeing on the slide is the survival from 1970s to 2001 at University of Pittsburgh database. And you can see that in 1970s, the number one cause of death was scleroderma renal crisis, or SRC. We found out in 1970s that if you give ACE inhibitors such as lisinopril or Zestril, it can really improve the survival. But if you look at from 1997 to 2001, the number one cause of death is cardiopulmonary involvement, pulmonary arterial hypertension, and lung fibrosis. So I think that's a very important message that as a rheumatologist, when I see patients, those are the key factors that we look at, trying to screen you for those things, and if you have it, trying to diagnose it and give you appropriate treatment for it. When you look at the pre-treatment era, there are now 8 or 9 FDA-approved drugs for pulmonary arterial hypertension. We'll talk about it briefly. But when you look at the survival of patients who had congenital heart disease, IPAH, CTD, connective tissue disease, most of them are scleroderma and HIV, you can see that 3-year survival was about 40%. So if you have pulmonary arterial hypertension and you have a connective tissue disease, the 3-year survival was about 40%. And here I'm talking about the pre-treatment era. I'm not talking about this day and age. When you look at people with scleroderma, the prevalence, that means if somebody does a right heart catheterization on you or try to diagnose you with pulmonary arterial hypertension, ranges anywhere from 8 to 13%. So that's pretty high. 8 to 13% have pulmonary arterial hypertension. The first study is from UK, France, Australia. If you look at the US studies, they are similar prevalence. And it's clear that when people come to the rheumatologist, this is the data from our French colleagues, come to the rheumatologist, they come in New York Heart Association class 3 and 4. How many of you know what NYHA is? So this lady knows everything. Maybe we should have you come here with me, and it's a test. This is how much can you do in day-to-day activities. New York Heart Association class 1 is that you are able to do activities of daily living. You are able to do vocational and avocational activities, you have no problem. And that's what we want people to be in. Class 2 is that you get short of breath or have difficulties, fatigue, and things like that when you exert yourself. In class 3 is that even a little exertion causes shortness of breath, fatigue, dyspnea. And class 4 is that you're in heart failure. Even sitting in a wheelchair or in a seat can give you shortness of breath. So what you're seeing here is that almost, if I see the numbers right out here, almost 82 to 83% of the people, when they are diagnosed, are already in class 3 and 4. So very few are being diagnosed in class 2, and none of them in this cohort was diagnosed in class 1. So why do we care? Why do we need to diagnose you early? If you look at the survival, and we are not even talking about the quality of life, we are talking about very hard events. We are talking about whether a person is alive or dead. If you are functional class 2, the blue line up there, the 30-year survival is about 75%. If you look at functional class 3, it's about 70%, and if you look at functional class 4, it's about 25%. So it really does matter whether you have functional class 2, 3, and 4. So how can we improve this? We'll go to you. What do you think? Early screening, do you agree? So how is everybody screened out here? They screen you with right heart cath every year? I hope not.
Oh, no, first was it
Echocardiogram. So how many of you get echocardiogram for screening? Almost everybody. How many of you get pulmonary function test for screening? Almost everybody. Okay. So I agree. I absolutely agree with you that screening is the way to do. And here is some of the data to show you how the screening is changing. I'm going to go back to the French cohort. The first one are the people, 674 people that I showed you briefly before, that did not have screening. I'm going to come down. I apologize. I can't see the numbers back there, so now it's better. I think that should be 67. It shouldn't be 674 people. But you can see that the people out there are 87. Most of the people were in functional class 3 and 4. People who had not screening, so they are referred to a cardiologist or pulmonologist when they are feeling short of breath. When they're feeling short of breath, you get a chest X-ray, you get a CAT scan, you get an echocardiogram. Your rheumatologist, your cardiologist say, I think you have pulmonary hypertension. So they send you for a right heart cath, right? And on right heart cath, they diagnosed you with pulmonary arterial hypertension. When you look at those 18 people on the right side, those are the people who were getting echocardiogram every year. So they were getting the echocardiogram. Does everybody know what echocardiogram is? Okay. So they were getting the ultrasound of the heart every year. And here it's clear that most of the people were diagnosed early on, functional class 2, majority of them, followed by functional class 3. But we are trying to capture people early on. Now, these people were treated. People who were diagnosed after they had symptoms were treated with 1 medication, 2 medications, some of them with 3 FDA-approved medications in Europe. And you can see that the 3-year survival was about 31%. So we really didn't change anything. However, if you screen early and diagnose early, you can see that 3 and 5-year survival is 81 and 73%. A huge difference. So the bottom line out here is that screening is the key. Now, how do you screen? So you all agree that screening is the key, and hopefully all of you are getting screened. Now, this is a biased group. Like I'm a biased speaker because I do scleroderma research. This is a biased group, people who are interested in scleroderma care. But we see people all the time in the community where people have never had echocardiogram. So I think when you go back to your support groups, I think I'm going to discuss how to do screening. It would be very helpful to let the other people in the support group know about the screening for pulmonary hypertension. So this was recommended in 2004. And they said every patient with scleroderma should have a baseline echocardiogram and pulmonary function test, and then do it every year. Is that what happens?
Yes.
Okay. Does it work?
Yes.
Okay. So I will show you some of the data showing that, well, let me show the data and let the data speak for itself. So I'm going to show you the study that we just finished and published called the DETECT study. The DETECT study was a study of almost 500 people with scleroderma around the world. Some of you here must have participated in it. Anybody here who participated in the DETECT study? Not a single one, wow. So there were 500 people. It was an international study. And we wanted to develop an algorithm that could really do a good job at screening people with scleroderma. So everybody who came had a low diffusion capacity. When you breathe into this pulmonary function machine, we look at DLCO. It was low, which is high risk for developing pulmonary arterial hypertension. Everybody had a right heart cath, echo, EKG, lung function, 6-minute walk test, blood test. You can think about anything. Everybody had everything. So you can see that if you look at that people, 466 people participated, 19% of the people had pulmonary arterial hypertension. Pretty high. 1 in 5 people had pulmonary arterial hypertension that were not screened, or they were screened before but not thought to have pulmonary arterial hypertension. So here are a group of people walking into our offices. We look their lung function, it's less than 60%. We say, okay, you want to participate, we will do this and this because we worry about, and 19% of the people had pulmonary arterial hypertension. 6% had left heart disease. So here I want to distinguish, and then we'll move on with the DETECT study. What is the difference between pulmonary arterial hypertension and pulmonary hypertension? Pulmonary hypertension is a hemodynamic observation. What it means is when a cardiologist or a pulmonologist puts a catheter into the right side of the heart, they look at the pressures. And if the pressures are elevated, they say you have pulmonary hypertension. Now, pulmonary hypertension can come from the right side of the heart, like showed here, which is called pulmonary arterial hypertension. It can come because you have lung fibrosis. When you scar the lower part of the lung or the upper part of the lung, the oxygenation is impaired, and that can cause elevation of pulmonary pressures. It can cause by fibrosis of the small capillaries, vessels called PVOD, or it can be caused by left-sided heart failure or heart disease. What's the most common cause of pulmonary hypertension in scleroderma?
Right heart disease.
Left heart disease. So the most common cause of pulmonary hypertension in scleroderma is actually the left heart disease. Most common cause of pulmonary hypertension in the general population is left heart disease. That's why it's very important. And how do you distinguish that, whether it's right heart disease versus left heart disease? Wedge pressure, okay, but you have to have a right heart catheterization. So echocardiogram is a good screening tool. Echocardiogram is not the gold standard. To make a diagnosis, whether it's coming from the right side, left side, lung fibrosis, everything, we have to look at your lung function test, but right heart catheterization is a gold standard. So if you look at the right heart catheterization, it's a very, very safe procedure. If you look at the DETECT study, out of almost 500 people, there was not a single complication. If you look at the deaths that are associated in over 12,000 right heart caths that have been done in Europe, there has been 1 death associated with the right heart cath. So there are very, very, very rare complications. Like any invasive procedure, it can happen, but this is a gold standard to diagnose pulmonary arterial hypertension. So this is an example, if you like seeing pictures. On the left side is a patient of mine who has a lot of lung fibrosis. You see all the fibrosis on the left side, and it can increase the pressure. And the right side, the lungs look beautiful, but the heart is a bit dilated. And I don't have a pointer, but the pulmonary arteries are big, suggestive of pulmonary arterial hypertension. So in the DETECT study, we are back on the DETECT study. So everybody agrees here that echocardiogram is a good screening tool, right? Okay. So here are different pressures, 35, 40, and 50. So this is the first study ever where people had echocardiogram, and irrespective of what echo did, people had right heart cath. In the past, what happens in clinical care is you go to a cardiologist, they do echo, and the rheumatologist or cardiologist look at your echo pressures and say, you might be at high risk, let's do a right heart cath. So this is what it showed. In patients who had echo pressure of less than 35, where we would call it normal, 20% had pulmonary arterial hypertension. So the echo, a normal echo, quote unquote, missed 20% of the people. If your echo pressure was less than or equal to 40, 36% of the people had pulmonary arterial hypertension. And if your echo pressure was less than or equal to 50, 63% of the people had pulmonary arterial hypertension. So the point here is echo is as good as the person who's performing it, A. B, echo is not the gold standard. Therefore, it's called a screening tool. If it was a perfect screening tool, then you won't need to do a right heart catheterization. So the first two, a lot of us, including me, used to think are normal, 35 and 40. No longer. So echo is a screening tool. But it's clear out here that if we have just focused on echo, we would have missed up to 36% of people who had pulmonary arterial hypertension with a pressure of less than or equal to 40. Is that clear? I just wanted to emphasize this point. So what happened, I don't want to bore you. There will be a calculator that your physician will use. What we came up with is we combined what a rheumatologist would do in clinical practice. You see a patient, we do a FVC by DLCO. We do your lung function test. We see whether you have telangiectasias. Everybody knows what a telangiectasias is? They are dilated vessels on your face. We see what your anti-centromere, if you have anti-centromere antibody. Everybody knows what the centromere pattern is, body is, positive or negative? No. Okay, so if you have limited disease, limited or CREST syndrome, you probably have centromere antibody. Those people are at a high risk of developing pulmonary hypertension. We look at a blood test called BNP. When the heart gets stretched, the BNP goes up. Serum uric acid, that's associated with gout, and look at EKG or ECG. Look at what the score is, and that takes us to the echocardiogram. And if you have high enough score in both of them, you get a right heart cath. Now the question to ask is, why do all this fancy jumbo-bumbo mathematics statistical, right? Why not let's stick with the echocardiogram? I showed you why not stick with the echocardiogram. Here's another example. If you just follow echocardiogram, look at the third column, you would have missed, or we would have missed 29% of the people who had pulmonary arterial hypertension. So we would have missed 1 in 3, 1 in 4 people who had pulmonary arterial hypertension. If you put the detect algorithm at work, we only missed 4% of the people. So the third column again, 4% of the people were missed. So we captured an additional 25% of the people by using this algorithm. And that's very, very important when I'm showing you it's the #1 cause of death. When I'm showing you if you already have a lot of symptoms, we probably can't do a lot to improve the survival. So that's very important, when you go. It will take some time for the rheumatologist and for the other people to percolate down into the practice. But I think you are your own advocate, so I wanted to bring this to you.
Can you explain more about what the detect algorithm is? That part of an echo then, a special way of looking at an echo, or is that something different?
No, so detect algorithm, there are 2 steps. The step 1 has nothing to do with echocardiogram. The step 1 is a physical examination, which is a telangiectasias, a lung function test, a blood test, and an EKG. So those are the ones that are listed here. Depending upon where you score, and there would be a website where doctors will put the numbers and see what your score is. If you meet that score, you look at the total risk points from step 1, and it says referral to echocardiogram, then you go for echocardiogram. The next step is the echocardiogram. And if the echocardiogram scores are high enough, then you go for a right heart cath. Yeah, so the question is, how many telangiectasias do you need? In this analysis, we said any. But if you look at the Johns Hopkins paper from their center, they said the more you have, the higher likelihood you have of having. But here it is any telangiectasias. So how is pulmonary arterial hypertension diagnosed? We talked about the symptoms. The problem with the symptoms is the shortness of breath, the fatigue is very, very common. In scleroderma, shortness of breath can come from lung fibrosis, come from pulmonary hypertension, can come from anemia, can come from deconditioning, can come from heart disease, right? So it's multifactorial. Here they're talking about idiopathic pulmonary arterial hypertension where a 30-year-old person or a 40-year-old person develops it. Fatigue, how many of you are fatigued? Almost everybody is fatigued there, right? Now, not everybody has pulmonary arterial hypertension. Again, the multifactorial aspect of scleroderma makes these hard. And by the time you have palpitations, which is the heart beating fast and you're hearing it, chest pain and leg swelling, which could come from other things, but then you already are in New York Heart class 3 and 4. So we have lost that window of opportunity where we want to really make an effort. So here are the two chest x-rays. Again, on the left side, you're looking at the pulmonary arteries out here. And the pulmonary arteries on the left side are not big. On the right side, those are the pruning that's coming around your heart. And that's consistent with very severe pulmonary arterial hypertension. Anybody, a medical student, should be able to look at it and say, well, this is pulmonary arterial hypertension. Patient probably is in complete heart failure or is very symptomatic. We can do EKGs, and we can do echocardiograms. We talked about the echocardiogram. On the left side is a normal echocardiogram. Where you see LV, left ventricle, you see the left ventricle of the heart is bigger than the right ventricle. When you look at the right side, that big mass that you're seeing is the right side of the heart. So in pulmonary hypertension, the right side of the heart starts to get dilated. And it's trying to beat, and after a while it gets tired and it says, I'm done. And that's called right-sided heart failure. And that's when people start becoming very short of breath, start getting swelling of the legs and other symptoms. So the diagnosis, again, is right heart catheterization. I can't emphasize enough how important is right heart catheterization. We have found, so I talked to you how echocardiogram can be false negative. In other words, the echo pressures are quote-unquote normal, but you do a right heart cath from the DETECT study, and you had pulmonary arterial hypertension. In about 1/3 of the people, the echo pressures are like 74 and 80, and you do a right heart cath, and the right heart cath is normal. So it can be false positive, it can be false negative, and therefore, before you go on these medications, before we understand, and the another reason to do echocardiogram is it helps us how you will respond to a medication. How aggressive do we need to be with the medication? The higher the pressure, the heart is failing, we'll probably give you an IV medication. So all those important information is required to do an echocardiogram.
How often should you have a right heart catheter? I mean, I had one 4 years ago, but if
I can't see where the question is coming
normal, should you?
Oh, there you are.
Yeah. Should you be having one every 2 years, 4 years, or is there any kind of frequency that you had one?
So it's a hard question to answer. So if you had a right heart cath and that's normal, the next right heart cath really depends upon if you're developing changes in your echocardiogram again, if they're changing, your diffusion capacity is starting to go down. There's no clear-cut answer out here. I mean, we are trying to have the first step, which is yours, to get a right heart cath. So there's no clear-cut answer, but if you get more symptomatic, or you still should be getting the screening done every year, every other year.
If you're on a medication that you're using because of digital ulcers, but it's also used for pulmonary hypertension, does that affect your screening?
It may, and I think that's an important question. All the medications that we use for the treatment of pulmonary arterial hypertension, they're also effective. Not in a rigorous clinical trials, apart from one I'll talk about, Bosentan, where there's a clinical trial to support it. But we have a lot of experience using Viagra or Revatio or Cialis for the treatment, or prostacyclin or endothelin blockers for the treatment of it. So what we do is we have people stop. We usually don't recommend to stop your pulmonary arterial hypertension medications if you have PAH, because there could be a rebound vasoconstriction. But when you are taking for digital ulcers, it's safe to stop it for 3-4 days before we do the right heart cath. So the treatment is to increase the function of the heart. If your heart is failing, we want to have the heart try to beat again at an appropriate rhythm and at an appropriate strength, so it can push the water, it can push the blood, it can push it out into the body. We want to improve your exercise capacity. A treatment for a heart failure without you feeling well is worthless. Any treatment without symptom improvement for a patient, whatever disease it might be, is worthless. So we want to improve that. We want to improve your function, and we want to, of course, improve your survival. So these are the medications that pulmonologists and cardiologists tend to use. Digoxin. Anybody on digoxin here? One. See how rare these are becoming. This is to increase. So if you have heart failure, it's to increase the contractility of the heart. Lasix. How many of you are on Lasix? A few of you are on Lasix. Lasix is given to remove that extra fluid. Now, Lasix is sometimes given not because of heart failure, so it's not that if you're taking Lasix. Aldactone, same thing. Coumadin for pulmonary hypertension, only one. Two. Two of you are taking Coumadin, three, okay. So it's rare to use in scleroderma, but it's a blood thinner to reduce the platelets from sticking each other when the vessels get narrowed. Calcium channel blockers, if you look at the patients who have idiopathic pulmonary hypertension, and if you give calcium channel blockers during the right heart catheterization, and they have a beautiful response, their blood pressure really drops in the pulmonary circulation, that's a good thing. In scleroderma, it really has no role because the dose you have to use is about 4 to 5 times the dose you use of amlodipine or nifedipine for your digital Raynaud's phenomenon and digital ulcers. So we do know, we know there's no cure, but we do know, based on size, that endothelin is a protein that's very elevated in patients who have pulmonary arterial hypertension. As far as we know today, it's the most potent vasoconstrictor in humans. In other words, endothelin is probably the most potent vasoconstrictor that constricts a vessel, whether it's the digits of the fingers, whether it's the heart vessels. Nitric oxide levels are reduced, and prostacyclin levels are reduced. So again, it's a yin-yang. It's the normal blood circulation should have appropriate vasoconstriction and vasodilatation. You go out in the cold, your blood vessels should constrict. You wake up from lying, you stand up, the blood vessels should constrict, so the blood pressure is maintained. What's happening in digital ulcers, Raynaud's phenomenon, there's too much vasoconstriction happening, and that's akin to what's happening in the pulmonary circulation. So these are the FDA-approved medications. The prostacyclin are usually given to people who have more severe pulmonary hypertension. So let's say class 3 and 4 as an example. Then we have the endothelin blockers that has a lot of data. There are 2 of them that are approved here, bosentan or Treclear, ambrisentan, or Letairis. Anybody on these medications? Okay. Anybody on prostacyclins? Nobody. And then we have the sildenafil and tadalafil, Revatio, and forgetting the names of Cialis, Etcirca. Anybody on these medications? So a lot more. Because of pulmonary hypertension or because of digital ulcers? Pulmonary hypertension, same for you? Both. So that's not uncommon, especially when I moved from Los Angeles to Michigan. I started seeing more severe digital ulcers than I saw in Los Angeles. So for us, with the pulmonary hypertension colleagues, use PDE5 inhibitors like Revatio or Etcirca because that tends to do a better job in healing digital ulcers in these people. So again, each patient is different. It's good that we have more options. When we have more options, we have more decisions. How many of you here are taking more than one medication that I showed? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you can see that it's moving. The times have changed. It used to be that we used to pick one of these medications. In this day and time, we have realized that combination therapies is the way forward. We realized that in rheumatoid arthritis about 10 years ago. Use methotrexate with another medication. We have realized that in pulmonary hypertension. That combination therapy is a much more stronger, much more robust way to treat a person compared to a single therapy. Now, most of the doctors, when they treat you, they probably start you on a single therapy, they reassess you, and if you're not improving, they add another medication. There are studies going on to see whether you start 2 medications up front versus 1 medication and add on, and if there are differences in the overall endpoints. I'm just looking at the time. This slide talks about that again. It really depends upon the physician and the patient and the circumstances. So as an example, if you give subcutaneous prostacyclin, something like Remodeline. Anybody on Remodeline? Anybody ever tried Remodeline? I'm just taking an example. It can give severe pain, burning pain in the skin. So, in your case, then somebody might move to IV prostacyclin, which is a little bit more headache because it's a continuous pump if you look at the epoprostenol, but then that might be an appropriate decision for you if you can't tolerate the burning pain associated with prostacyclin therapy. Every time you come to your pulmonologist or your cardiologist, rheumatologists usually don't treat pulmonary arterial hypertension. I don't treat. I screen them. I send them to my cardiologist. He or she diagnose them, and those are the ones that initiate treatment. And that's usually the case. Rheumatologists, and our job as rheumatologists is really out here to facilitate this referral, early screening to the appropriate people who can then do a right heart cath and make the diagnosis and initiate the treatment. One of the key points I forgot to mention in the DETECT study was that people who were diagnosed much, much earlier. So we don't know how those people are doing. We are still trying to follow that data. But when we proactively screened those people, when we proactively did those right heart caths, I showed you that 20 to 36%, we didn't suspect on echocardiogram they have pulmonary hypertension, but they did. But those people were diagnosed much, much earlier, what we want to do, and they were treated appropriately at that time. But every time you come, whoever you see should be doing a 6-minute walk test. They make you walk for 6 minutes, right? They must be looking once every 6 months or a year echocardiogram to see how the heart is doing after the treatment. They must be doing blood work to look at the BNP or the NT-proBNP to look at the stretch around the heart and how those levels are doing. And also looking at whether you have been hospitalized because of your pulmonary hypertension. And all of those factor in when we add another medication or a third medication or a switch of medication for pulmonary hypertension. Just to show you, different devices that are available, and then, of course, there are pills that we talked about that are available. Now, I just wanted to show you this data from UCLA. While I was there, now we have 28 people who have had bilateral lung transplantation. So pulmonary hypertension, we want to treat it aggressively with the medicines. Nobody likes to get their chest open and get new lungs, right? That's not what we live for. These are the people, 14 people with scleroderma and 38 people with idiopathic lung fibrosis, IPF, which is a scarring disease of the lungs that we don't know what causes it. So most of the people in scleroderma had pulmonary arterial hypertension. Some of them had severe lung fibrosis. So these people underwent bilateral lung transplantation, and you can see that at 36 months or 3 years, the overall survival was about 75%. And that's consistent if you look at the 28 people that have been transplanted at UCLA. And it's consistent if you look at Cleveland Clinic and other large centers who do. So just to point out, if the medicines don't work, we tend to be aggressive, and therefore, whoever you see, if you already are in class 4 pulmonary hypertension, if you already have heart failure, and if the medications are not helping, this could be another venue for you. So I'm not going to spend much time here, but just to say, how's your quality of life? Are you able to do the things that you enjoy doing? How's your heart doing? How the blood oxygen levels? Do you still need oxygen when you do day-to-day activities? Are you able to get off oxygen once you started your pulmonary hypertension medications? And we talked about the side effects. Can you tolerate the side effects of the medications? I think the critical thing that people talk about, and we always ask, that's very, very important to people is, are you able to get up a flight of stairs without feeling undue shortness of breath? It's a simple question. But for day-to-day activities of daily living, that has such important implications. And then there are some chest pains, fainting episodes, how much adequate energy you have, again, going over the quality of life issues. So you guys are the center of attention, and you should be. But there's a group of people who work around you. And I think our role as a rheumatologist is a very critical role and a very important role, because the screening usually starts at a rheumatology office. Your primary care physician is probably not going to do screening. I mean, most of the primary care physicians have maybe 5 scleroderma patients in their practice, maybe 4 scleroderma patients in their practice. So they are probably not going to be the one who's going to be initiating the screening. It should be a rheumatologist. And you will not be seeing a lung doctor or a cardiologist without being referred to them, unless and until you have another medical problem that's going on. So it's really your rheumatologist's job to initiate that screening, coordinate with a cardiologist or a pulmonologist, bring your primary care doctor into this, and then, education and the respiratory therapist. Some of our patients go through cardiopulmonary rehab. Once you have maximized therapy and you have been so deconditioned because you have been so scared to do anything, we want to increase your metabolic profile, start to exercise again to improve your strength. And this just talks about some of the things that we all should be doing, living a healthy lifestyle, so there's nothing unusual out here. But again, the common sense issues, taking the medication when you are prescribed, keeping a journal for the side effects, and again, being your own champion, being your own advocate when it comes to the management. Now, what to avoid? If you have pulmonary hypertension, the 2 things that you really need to avoid is, get pregnant, because if you get pregnant with moderate to severe pulmonary hypertension, you have a bad outcome, both for the baby and for the mother. Fortunately, most of the people who have scleroderma already had kids, and they either don't want or they are happy. And you shouldn't be on oral contraceptives. Oral contraceptives are associated with blood clots that can make your pulmonary hypertension worse. Diet pills. There are still people, I just saw the patient the other day who's still taking diet pills after having pulmonary hypertension. I know people want to lose weight, I understand, but diet pills are fen-pen, are cause of developing pulmonary arterial hypertension. Nobody smokes here, right? Well, even if you do, you're not going to raise your hand in this group. Sodium intake, smoking, not smoking, exercising, healthy weight, and again, really being in close contact with your healthcare team. I think pulmonary arterial hypertension is really managed for people who, like you see somebody at a university. It's really not the cardiologist or pulmonologist, it's the nurse practitioner and the nurses who do a wonderful job, make sure you're getting your blood work, if you're on some medications, making sure the side effects are being managed appropriately. So having a really good contact and relationship with them make a huge difference. Pulmonary arterial hypertension is a complication. 1 in 4 or 1 in 5 of people with scleroderma will develop PAH. We know that. We know that from different studies. We know that it's progressive, and sometimes it's very rapidly progressive. But the good part is we know there are multiple therapies that are there. But hopefully, as a patient, what you have under your control, as a rheumatologist, what I have under my control is to do the appropriate screening and refer you to the right person for a right heart cath.
The list of things that we should minimize, you had said we should avoid over-the-counter decongestants? Why?
Well, the decongestants being, if you're taking a lot of Claritin D, so if you're decongested, I'm not talking about Afrin, but I'm talking about Claritin D, anything that has a D in that, because that can again cause vasoconstriction of the vessels. So we are trying to avoid. Sometimes taking decongestant is okay, because if you're feeling, but some people are taking Claritin D or Allegra D on a daily basis because of their allergies and things like that. So we tend to avoid that. Anything that will cause vasoconstriction, we tend to avoid those medications.
Okay, on the testing that can be done, is the BNP test the same as the NT-proBNP? And should we be having the endothelial concentration, nitric oxide, and prostacyclin done frequently?
Very good question. So NT-proBNP is a step before BNP. So it's a pro form, like we call in medical term. They tell you very, very similar things. So it depends upon your hospital and lab. In US, most of the people do BNP. In Europe, most of the people do NT-proBNP. And what it's telling is the stretch around your heart that's happening. There are no commercial tests available for either of the three, the prostacyclin, the endothelin, and the nitric oxide. But if you look at people who have died because of pulmonary hypertension, and you look at people without pulmonary hypertension, and you try to stain those pulmonary arteries, there you see the expression, a medical term expression, how much light it absorbs. For prostacyclin and nitric oxide is much lower in people with pulmonary hypertension versus without, and endothelin levels are much higher. There are tests that you can do in research setting. You can do an endothelin level, but they are not commercially available. And we don't know how that would change the treatment or the management of the disease.
I had a question about, you were talking about the heart catheterization, and I wonder, are there patients that refuse to have that done because they're afraid of it?
So is anybody here been treated for pulmonary arterial hypertension without a right heart cath? I'm sure there are a few. So one. So you chose not to do the right heart cath?
No, initially the reason they started me on Tracleer, I've lost a part of my finger, digital ulcers, and when they did some of the tests, it showed very, very mild, and didn't really know whether to put me on the medication, but my rheumatologist talked to someone from Actelion, and they discussed it, and he ended up putting me on the Tracleer. And it has improved, but I mean, I still get them. But I go, I have an echo every year. I have all the series of blood tests and the echo, the chest x-ray. I have that every 4 to 5 months, and he does an echo every year. And they've really just stayed right. I mean, they have not increased. And I don't really have a lot of symptoms, thank goodness, right now, with the PAH.
So, I think that is appropriate. So Bosentan or Tracleer, it's not approved in US, but in Europe, it's approved for prevention of digital ulcers. There are 2 large studies showing that improvement. So, even if your digital ulcers is not good, so more and more insurance companies are mandating people get right heart cath before getting these therapies. So let's say you need another therapy even for your digital ulcers. They would mandate a right heart cath. But you can see there's only one person amongst the people who have pulmonary arterial hypertension, and she has a compelling reason, where she's already on a therapy, and the echo follow-ups and everything have been within normal limits.
And I'm taking Revatio now also.
You also take the Revatio?
TID, I take that.
Okay. By the way, if anybody needs a slide, you can, it was a lot of slides, and for them to print, so you can email me, that's my email, or you can, call the Scleroderma Foundation, and they can give you all these slides. So
one of the screening tests that you mentioned was EKG, and then you went by it.
Oh, I'm sorry, I was doing it.
Sorry. One of the screening tests you mentioned was EKG, and then you went by it. Tell me what you would see that would indicate pulmonary arterial hypertension on an EKG.
Yeah, I can go back, but it's something called right axis deviation. So those are early signs that can happen on the EKG.
Does lung fibrosis increase your risk of developing PAH?
So where are we getting? Oh, getting the question from there. Does a lung fibrosis? So if you have moderate to severe lung fibrosis, you have pulmonary hypertension, but that's not PAH. Pulmonary arterial hypertension is different than pulmonary hypertension. If you have a lot of lung fibrosis and scarring, it can increase the pressures in the right side of your heart. However, 70% of the people with scleroderma have some kind of lung fibrosis. So it's a decision that, the individual cardiologists, rheumatologists, pulmonologists make, whether this is pulmonary arterial hypertension or this is pulmonary hypertension due to lung fibrosis. And that's a very important question because when a person comes to us, they don't read the textbook. We have artificially divided people into PAH, left heart disease pulmonary hypertension, lung fibrosis pulmonary hypertension. But if a 60 or a 70-year-old person is coming who has moderate lung fibrosis, who have some degree of left heart disease because, they're getting old and they might have some atherosclerosis or coronary artery disease. So it sometimes gets very difficult to put people into these bins, and we try to make the best judgment call at that time. For example, treating people for lung fibrosis and also treating people for PAH.
When you have a lung transplant, if you have pulmonary hypertension, would you also get a heart transplant? Would it be heart and lung, or because isn't your heart enlarged and messed up, or is it usually just the lungs and then the heart recovers?
It's usually just a lung transplant, unless and until you have heart involvement, scleroderma heart involvement, with heart failure, something called cardiomyopathy, but it's just but you need bilateral, both the lung transplants.
Thank you.
Do we all need to move to Europe? Or is Europe and the rest of the world being used as our guinea pigs?
Well, I say we should all move to Europe. I mean, Florence to be exact, or Rome, but that's my view. No, actually, it's happening here too. The Europeans have to be given the credit because those people have been publishing, and they have this very large network where they're systematically collecting data. While I was at UCLA, we were doing that. While I'm at Michigan, we are consistently screening people. But doing something and then publishing data and trying to show the world, yes, it makes a difference, Europe gets the credit for that. But you can move to Paris. I mean, that's where they...
You had mentioned that when you got the echocardiogram, the technician, like this goes back to awareness, I guess. When the technician is looking, does he know what he's looking for in a scleroderma patient versus somebody else that's getting an echo? And could it be like incorrectly read, or because he hasn't, done the right or left heart more so than the other?
Yeah, so it's a tough question because it depends where you're getting the echocardiogram and the experience of the technician and the experience of the cardiologist who's reading it and the interest of the cardiologist. So there are 4 or 5 factors that come into play. The simple question is, if you look at a study we just did and about to publish called Scleroderma Query, in 50% of the people, there was no mention of the TR jet, the tricuspid jet. So when I showed you those echo pressures of 35, 40, they come from a TR jet. So 20% of you out here don't have a TR jet, and that's normal. So in 20% of the people, those pressures cannot be calculated, and they are a sophisticated way to look at the right side of the heart. But if you look at the journal practice of cardiology in US, it was a snapshot. 50% of them didn't report it. So it's very hard to make it into a very good screening tool or a believable screening tool. Having said that, there are cardiologists and there are practices who have a lot of interest in looking at the right side of the heart. The bottom line for you guys is when you go out to get a right heart, to get an echocardiogram, you have to emphasize to them that they must be looking at the right side of the heart in addition to the left side of the heart. And the cardiologists are getting much and much better. It used to be they just reported the left side of the heart, and they would say right side of the heart, no abnormality, without providing all the pressures and things like that. And the problem by saying no abnormality is that your pressure could have been 40. But if they don't provide us that, now I can look at a person with 40, and I can say, based on the detect, there's a 30% chance that you can still have mild pulmonary hypertension. And now we can do a detect algorithm on you and try to reduce that chance from 29% missed to 4% missed cases. But it's so cardiologist, so technician dependent, so there's no simple answer to the question.
Yes, I've had one heart cath. I have diminished lower lung capacity, and they said that my pressures were lower. But then when I did the echocardiogram, based on her question, I just remember when I did the echocardiogram, the doctor wouldn't take it from the technologist that did it. He made me come to his. So I had to redo the echocardiogram. But my question is, I'm scheduled to go back through the entire 6-minute walk again, and the echo and the cardiac cath again in 6 months. So what are the chances of me having pulmonary hypertension? And I have systemic scleroderma.
So when was the last time you had a right heart cath? How many years ago?
8 months ago.
6 months ago?
6 to 8 months ago, yeah.
And why do you use oxygen?
When I did my walk test at MUSC in South Carolina, it was 91%, and that was in January. And when I went and did it 2 weeks ago, I was at 83%.
And do you have lung fibrosis?
Pulmonary lung fibrosis is what they told me.
Okay. So here is, you know, how a real person is different than what the books teach you, right? So you had the right heart cath. The right heart cath was negative, right? You have lung fibrosis, and if you have scarring of the lungs, it can ask you for more oxygen. You get short of breath. But I think the trigger to them was that when you walked, your whole walk went from 91% to 83%. So there's something rapidly happening in two areas, either the heart or the lungs. So if the lung fibrosis is stable, and I don't know whether the lung fibrosis is stable, then the culprit is likely because of the heart coming. Now, it doesn't have to be pulmonary hypertension only. It could be left-sided heart failure. It could be a lot of different things. Your oxygen saturation could be low because you're anemic. You know, some people with scleroderma have watermelon stomach. Dr. Gladu is sitting back there. She will do 2 lectures on GI involvement today and tomorrow. And you know, if you're bleeding and if you have low hemoglobin, hemoglobin carries the oxygen. So that's why your saturation could be low. But I think that's why somebody asked me before, when do I get a repeat right heart cath? And I absolutely agree that, you know, we really want to diagnose and treat it. Because we know that we have therapies and we know the outcomes are not good if we keep on waiting. So I think that's very appropriate to do a right heart cath. And I can't say anything against Dr. Silver anyway, so.
Hi, Dr. Khanna. I just want to address the whole PF and the PH and the PAH. If you are a new patient and they say you have ILD, and then say 8 years later, they're calling it PF, does the ILD equal the PF, or did the ILD get worse that they call it PF? And then you just said PF moves into, oh no, would PF move into PH eventually? And do they do the echo on the left side, or how do they know? How
so
do you
PF
know?
and ILD are the same thing. So
it is the one and the same. Okay.
So interstitial lung disease is same as pulmonary fibrosis.
Okay.
It becomes idiopathic IPF, idiopathic pulmonary fibrosis, if you don't have scleroderma or any other known cause. So that's the first part of the question. Sometime, you know, if you go to a rheumatologist or a pulmonologist might call it pulmonary fibrosis, a rheumatologist might call it ILD, and it depends. But they are one and the same things, number one. Number two, lung fibrosis, if it's moderate to severe, because of the scarring that's happening in the lungs, and the lungs have the alveoli or the small capillaries and the vacuoles through which the oxygen and the carbon dioxide go back and forth. Because of the scarring, it can increase the demand and cause pulmonary hypertension.
Okay.
Now, moderate to severe, you know, the data is not clear. If you look at DETECT, there was 6% of the people who had because of that. I would say 10 to 15% have that.
Okay.
At that time, if the pulmonary hypertension is due to lung fibrosis, the treatment is oxygen. Right. Because you want to give it more oxygen, so there's more oxygenation that's going on. However, having said that, some people have mild lung fibrosis and still have very high pulmonary pressures. And that's where we tend to choose starting both a pulmonary arterial hypertension medication and putting you on oxygen. The lung fibrosis usually is progressive early in the disease.
Okay.
And pulmonary hypertension is usually a late complication. Having said that, don't make your physicians say, well, you don't need an echocardiogram because you just were diagnosed with disease. We just saw 3 patients over the last month whose first symptom of onset was pulmonary arterial hypertension. First symptom in their 20s, all 3 in 20s. I don't know why all 3 girls in 20s who came with severe pulmonary arterial hypertension. And the echocardiogram or the detect screening has to be, I would say, for a long time, even lifelong. So once you're diagnosed with systemic sclerosis, that needs to be done.
Okay. Dr. Khanna, we had a patient male in Texas that he eventually had a double lung transplant, and he's doing very well. However, we were told, and he's in our support group, that they really scrutinize over giving that okay because of our gastro issues and our acid reflux. So he had to agree to be on a feeding tube before they would do that for scleroderma patients. What's your take on that?
I will have Dr. Gladu address that. That would require me 10-15 minutes to answer that question. But the bottom line is that, once you get lung transplant, they want good motility of the gut. And we know in scleroderma, the motility is not gut. There's aspiration occurs. When aspiration occurs, the rejection occurs. And that's what the pulmonologists don't want to see. But Dr. Gladu has few slides that she's going to address those questions.
Yes, Dr. Khanna, my question is on lung transplants. I don't understand why it's even offered as even a last resort to scleroderma patients when scleroderma patients are awful candidates for a transplant. And also, when you consider the suffering involved with a lung transplant and the short term of life after you get it, why is it even offered as an alternative, as an option?
So when the medical therapies fail, then we are going into very individual preferences in life. Some of you out here had stem cell transplantation. Stem cell transplantation has a 10% chance of dying within 90 days. But people choose stem cell transplantation for their scleroderma. I think the individual decisions cannot supersede. There are medical treatments that we as doctors do which are FDA approved. And then when we have tried all of those, and if there's no other medical treatment to try, we are trying to offer the people, look, this is the best we can do, or we can try the lung transplant. I think your information regarding the survival is misinformed. If you look at the survival around the world of scleroderma people who have lung transplant, they have ranged anywhere from 60% to 85% up to 5 years. If you look at the survival of people with moderate to severe pulmonary hypertension who have been treated with medications, it can range anywhere from 20% to 50%. So I agree it's a difficult, and there is no clear guidance around that. But I think as a physician and as a patient, it's really an individual preference. Do you really want to go through this experimental or not so experimental procedure? The same thing can be said about stem cell transplantation. People go to Northwest, people come to University of Michigan to get stem cell transplantation now with the knowledge that the first 90 days are going to be hell. There is a 10% chance of dying because of your ablation of your immune system.
Well, what I hear is mostly it's just a lot of suffering like you're mentioning, and then at the end of maybe, what is at the end of 1 year? What's the prognosis for a scleroderma patient?
With the lung transplant?
Yes.
So I showed you the 3-year survival is 75%.
That's survival at 75%.
75% at 3 years.
Okay.
And I don't have the latest data. And if you look at UCSF, University of California, San Francisco, their 5-year survival is 84%.
Okay, so it is improving then.
It is improving, but these are individual choices and preferences that there is no blanket treatment statements. Okay, thank you.